I'll be speaking about fibrin glue and amniotic membrane grafts for corneal thinning and perforation. What I'll try to do is I'll try to divide my talk into three parts where I talk about the fibrin glue a little bit, then about the amniotic membrane itself, and then how these can be used individually or in combination with each other. So we know that fibrin glue basically is a biological tissue adhesive and it's biodegradable. What it does is that it mimics the final stages of the coagulation cascade by forming a clot. So prothrombin in the presence of calcium gets converted to thrombin. Thrombin further converts the fibrinogen into fibrin, which then forms a clot as is seen in our body as well. Now the commercially available preparations, we have the Tissile by the Baxter and we have the Relicil by the Reliance. Instructions on how to form are given on the box itself. The components of the two are basically the same. So in the blue bottles, you have for the Tissile at least, you have the sealer protein concentrate, which contains the fibrinogen and the other components required for the coagulation. You have a protein which helps to delay the lysis of the clot, otherwise the clot would get lysed too fast. One has the calcium chloride, which is required for converting the prothrombin to the thrombin. And like I mentioned on the box, the instructions are given very clearly. The blue mixes with the blue and the black mixes with the black. And then these are put into the stirrer and the warmer, which gently shakes them so that the components get mixed well and then they function properly. The formed glue must be used within 4 hours of preparation. The unopened kit, however, can be stored at room temperature or preferably refrigerated between 2 to 25 degrees centigrade. Now, what is the advantage or disadvantage of fibrin glue over cyanoacrylate? The advantages are that it has a smooth surface and it causes less discomfort and it causes less vascularization. On the other hand, it has no bacteriostatic action, it gives less strength and it degrades quickly. The reverse is cyanoacrylate glue, which gives stronger adhesion, it lasts longer, the cost is very much lesser. It has an antimicrobial effect as well, but the disadvantage is that it induces a lot of vascularization if it remains for a long time. Coming to the second component, which is the amniotic membrane graft. So this we know is derived from the placental layers. It has to be taken from a cesarean section. It is not taken from a normal delivery to prevent the spread of infections. The mother must have been screened for the HHH, the HIV, and the other viral markers. And then these membranes can be taken. The amnion is separated from the chorion, and it basically consists of two parts. The basement membrane, which helps the epithelium to grow over it, and the stroma, which has other functions. So the amniotic membrane has a myriad of functions. It has a mechanical function. The basement membrane, like I mentioned, acts as a substrate for growth. It helps in epithelialization. It has a lot of growth factors like the epidermal growth factor and the hepatocyte growth factor, which help in healing. It is anti-angiogenic, so it prevents excess vascularization. It has antimicrobial actions, a lot of bactericidin, beta-lysine, etc., and it is also immunomodulatory. The placement of the amniotic membrane, how it's placed is important. It can be placed as a single layer or it can be placed as a multiple layer technique. In an inlay, the amniotic membrane is made smaller than the side of the defect and it is placed within the side of the defect as a single layer or as multiple layers. The purpose is here that it should get integrated and provide strength and volume to the tissue. So in this cases, the stromal side has to be kept down and the basement side up so that the epithelium is able to grow over it from the surrounding tissue. On the other hand, in an onlay, it's used more like a bandage contact lens. We expect the epithelium to grow under it, and which is why we keep the stromal, here we keep the basement side down so that the epithelium grows under it, and it is kept larger than the graft, for example, just like a bandage contact lens. And then one may have a combination of an inlay and an onlay technique. So these are just representative photographs, simple inlay, smaller than the graft, and onlay, larger than the graft. We have multiple types of AMG available. The most common is the cryopreserved amniotic membrane, which is stored at minus 80 degrees centigrade. But very easy for practitioners who don't have access to this is we get the dried forms of amniotic membrane, which are available off the counter. Stored at room temperature, these have a shelf life of 5 years, though I must say that they don't have the same flexibility and sometimes tear. So they are not as good in my experience as the cryopreserved, but if you don't have, they work decently well. And then we have the Procera, which is a sutureless form, which can be applied in cases of acute chemical injury. Now, where do we use this? They can be used single or in combination. So they are used for small non-traumatic perforations where we have loss of stroma, where we hope that the amniotic membrane will add up to the stroma. We can use it in desmatoseals where we suspect impending perforation because cyanoacrylate glue there may cause perforation. And we have, when there's a lot of stromal melting again, then in impending perforations, we can use this. So just to show a few examples, this was a 16-year-old male who had severe atopic keratoconjunctivitis and a lot of itching and rubbing of the eye. The AC was found, but the IOP was low, and the CDLs was positive on pressure. And we can see on the AIOC how the iris is plugging the cornea. So cyanoacrylate glue was not considered in this case because already there was a lot of vascularization, and in such a patient, tolerance to contact lens for a prolonged period was expected to be poor. And we can see the extreme degree of thinning. So this is a small video showing this. So basically the epithelial plug from the top was removed. Can we have the music please from there if it's running? An air bubble was put in, and then a spatula was used to remove the iris tissue plugging the perforation. The drying and the cleaning of the bed is important. This was followed by fibrin glue, which was placed on top and covered by the amniotic membrane, which acted as a bandage in this case. So we expected the fibrin glue to remain for a little longer, and then another layer was put, which really was not necessary in this case, and then it was just finished. And this is how the patient responded over 1 day and over 2 weeks. We can see there was evolvement. The stroma also kind of thickened up, and the patient did well. So now can amniotic membrane, I'm sorry, am I running out of time? The time is not visible from here. So can amniotic membrane and fibrin glues be used for large corneal perforations? For large corneal perforations, the success is not as much. It's better for smaller perforations. But it can be used by forming a amniotic membrane plug. That is, multiple layers of the amniotic membrane can be folded upon each other using fibrin glue, so it forms a thicker amniotic membrane that can then be cut and plugged into the perforation. Multi-layered amniotic membrane may be sutured without using glue. So this is again a patient who had a large area of thinning and a non-healing epithelial defect. And one can just use the amniotic membrane. So one creates a peripheral annulus to where the amniotic membrane can be tucked in. This is the one layer of the amniotic membrane which is being tucked into the sides of the cornea. And then an onlay graft being used, which then can be mattress sutures, long mattress sutures are put to kind of keep the amniotic membrane in place. And this patient healed well. And this is the last of the cases. This was a 5-year-old female with infective keratitis, and we had put cyanoacrylate glue centrally. But there was a lot of florid vascularization. So under GA, we plan to take her up for a fine needle diathermy so that the vascularization decreases. Because later on, we plan to take her up for an optical penetrating keratoplasty. But what happened here is that before doing the fine needle diathermy, I thought that there's too much of vascularization, so let me try to remove the glue because it had been quite some time. I removed the glue, and this is the fine needle diathermy being done using a 10-0 nylon suture and low heat cautery to coagulate the vessels so that the vascularization decreases. And after this, I just put in, because there was thinning, amniotic membrane was cut, and it was again put into as an inlay and an onlay onto the graft for providing structural support as well as letting the cornea heal well. So I'll just run through this video. This is inlay and then the onlay graft being put on top. And this is how the patient healed. This is 3 weeks post-op. We have a well-healed scar. The vascularization is reduced. And now, as soon as we get a chance, we are going to take her up for a penetrating keratoplasty. I will skip this last case. So to conclude, amniotic membrane and fibrin glue, it's useful for managing thinning and perforation in select situations, not in all. They have to be used judicially, either alone or in combination to get optimal results. Wherever we use fibrin glue for thinnings, we must use AMG. AMG, however, may be used alone depending on the situation. And the technique of application may need to be modified on a case-to-case basis. Small perforations can be used with the fibrin glue plug and then cover it with AMG. We may form the plug by the amniotic membrane itself by increasing its thickness by folding it upon itself, or we may use a multi-layered amniotic membrane with sutures.
Thank you, Dr. Chintan, for excellent presentation and showing us the use of fibrin glue with the